2, 1. We are live now.
Good evening, everybody. Today we are having a regular Friday musing, and it's honor for a Prayagraj organization to host this meeting. And it's our proud privilege we have our UPOA President elect Dr. Anup Agrawal and Secretary Dr. Santosh Singh is among with us. I will request Dr. Santosh Singh to please take the session and introduce Dr. Anup Agrawal and request him to say a few words.
Presently, Dr. Anup is presiding the function. So, welcome address by Dr. Anup.
Thank you. Thank you, Dr. Santosh. So I welcome you all to the most awaited Friday Musing program of UP Orthopaedic Association. And it's an e-initiative of UP Orthopaedic Association where we talk about and fix up some topic every Friday. And our office bearers are doing wonderful job. I congratulate Team Prayagraj and Maneeshi Bansal for organizing. I won't take much of time and request Dr. Maneeshi Bansal to please go ahead with the program. Thank you.
Thank you, sir. Thank you. Respected members, as our President, Sir Dr. Anup said, on every Friday we used to select some topics of common interest and we used to discuss among us these topics. And today we have taken a theme of common foot and ankle problems. I'm glad to have our dynamic secretary, Dr. Anup Santosh, as a faculty also. I will request him to start his talk on the syndesmotic injuries. Dr. Santosh, please.
Thank you, Dr. Manish.
Poonam, please mute others, please.
So I think it is visible now.
Perfect. Perfect. Just put in presentation mode.
It is in it is on full screen.
No,
Not
yet.
Still.
But on my screen it is on full screen.
Close it and again do it. Close it and again open it. I think this.
In the meantime, sir, I would like to welcome our three panelists who have joined today to honor us. The first one is Dr. Gyaneshwar Tonk from Meerut, Dr. CP Pal from Agra, and Dr. KD Tripathi from Prayagraj. I welcome you all, sir.
Thank you, Manish.
Among us is Dr. Jayant Sen from Jaipur, also is one of the faculty, and Dr. Younus from Allahabad. I welcome them also. Dr. Santosh, please start.
I'm trying.
Yes.
No, it's all right.
Perfect.
Yeah.
Perfect.
All right.
Yes.
Thank you so
Perfect. Go ahead.
much. Thank you. So I'm trying to evaluate some points regarding the syndesmotic injury. I am not a perfect ankle and foot surgeon, but I'm trying my best to keep this topic alive. So it's a very common injury, but diagnosis is not straightforward. We have to keep some points in our mind to diagnose this condition. That's why the optimal management is controversial. What is syndesmotic injury? It is a rupture of the interosseous ligament between tibia and fibula, whether it is associated with the fibular fracture or not. It depends upon the injury pattern. And there may be persistent instability and gap in the joint after bimalleolar fixation. So you have to aware about this condition when you fix the ankle on both the sides. So after fixing the bimalleolar fractures, you have to see whether there is a syndesmotic injury or not. Because it does not necessarily lead to ankle instability, but with the coexistence of deltoid ligament, it destabilizes the ankle joint. These injuries may be isolated or associated with the ankle fractures. So basically, what are the ligaments which giving the stability to the tibiofibular lower end fragment? So they are basically interosseous ligament, interosseous membrane, and the three important ligament at extreme distal point, that is the anterior inferior tibiofibular ligament as here, the posterior inferior tibiofibular ligament and inferior transverse ligament is present in between the AITFL and PITFL. The mechanism of injury is important to diagnose these type of cases, and it involves the forceful foot external rotation with concomitant leg internal rotation. Sometimes there are associated fractures which may include the Weber type C or Weber type B, and sometimes Meissner fracture is also there, which is at the proximal end of the fibula. The clinical examination is important much more than the radiological evaluation. So we have a different type of test. These are external rotation test, squeeze test, gravity stress test, and cross leg test. So we have to do these tests one by one to see where if there is no fracture, then we can judge what are the condition for this syndesmosis. After that, radiology is important, whereas the AP and lateral are the common views, because we have to evaluate the ankle fracture and proximal fibular fracture. So what we have to see, if we have to keep in mind this condition. So the indicators are the tibiofibular clear space, tibiofibular overlap, and we should stress on the medial clear space of the ankle joint. So what are these basically? This is the tibiofibular clear space, and this is the medial clear space, and there is the tibiofibular overlap. So in the radiology, we have to see these spaces and suspect the syndesmotic injury if there is a variation in these cases. So we have to know what are the normal radiology. So tibiofibular clear space should be less than the 6 mm. And if it is more, then there is a suspicion of the syndesmosis injury. Tibiofibular overlap should be more than 6 mm, and medial clear space should be 2 to 3 mm. So if there is a variation in this, then there is a suspicion of that. So as you see in this, the X-ray, there is a fracture of the lateral malleolus, and you can appreciate very well in the stress view that the clear space is increased. So the injury is there. Current evidence suggests that syndesmotic injury may not be apparent on a standard apiolateral oblique views. So when we suspect it, then go for the CT scan for the fracture evaluation and MRI for the ligamentous evaluation. Because as you see, the accuracy of AP X-ray 63% was 63%, Mortis is 71, MRI is 96, and if there is any doubt in the diagnosis, then the diagnostic orthoscopy is 100% accuracy in diagnosing these type of fractures. So what should be the indication for fixation of the syndesmosis? The stabilization of syndesmosis is unnecessary in stable fibular fractures, regardless of location and associated with the rigidly fixed medial malleolar fracture. And second condition is fixed fibula fracture within 3 to 4.5 5 centimeter of ankle joint in association with the deltoid tear. So syndesmosis fixation is indicated only for fibula fracture, located at least 4.5 centimeter above the ankle joint in the presence of a deltoid ligament tear. These recommendations are based on these two assumptions. First assumption is the intraosseous membrane tear is limited to the level of the fibula fracture. And the second is fixation of medial malleolus fracture is equivalent to an intact deltoid. So you have to keep in mind these two things. In this case, when there is an intraosseous membrane tear, you will find there is a gap between the tibia and fibula, and it does not exclude the necessity for syndesmotic fixation, since instability may vary occur due to intraosseous membrane tear. So how you intraoperatively assess the condition after fixing both the malleolus? The first is the cotton test. Apply a bone hook on the fibula to attempt to separate it from the tibia. If there is a more than 4.5 millimeter lateral shift of talus, then it indicates the syndesmotic instability. The second test during operation is the underfluoroscopy. On applying external stress, note for the increase in the tibiofibular clear space and decrease in the tibiofibular overlap. So you always must do these tests after fixing the bimalleolus. If after rigid fixation of medial malleolus and fibular fracture, there is intraoperative evidence of syndesmotic diastasis, then you go for the fixation of the syndesmosis. So what should be the goal of treatment? We should restore and maintain the normal tibiofibular relationship to allow healing of the ligamentous structure of the syndesmosis. If it is without fracture, then it is also known as high ankle sprain. This is usually not associated with the instability. That's why the conservative treatment is recommended, and gradual weight bearing as per comfort is allowed. And if associated with the instability, it will require fixation, and it is mainly by 1 or 2 screws. So the restoration of proper tibiofibular relationship involves regaining fibular length and re-establishing correct rotation and position of the fibula relative to the tibia. So accurate restoration of fibular length is necessary to avoid talar subluxation. That's why open reduction and stable fixation of fibula fracture is always done and recommended in these cases. When fibular fracture is in the middle or proximal 1/3, length and rotation can be restored indirectly. And if it is achieved, there will be an unbroken shuntal line of the ankle. So how you assess after the reduction? If there is a equal joint space all around and intact shuntal line is there, this is the intact shuntal line, and unbroken curve between lateral talus and peroneal groove of the fibula. As like in this, if it is fibula is shifted upward, this curve is broken down. This is known as Dimes test. So what should be the surgical technique if we plan for the fixation? So screw should be parallel to the joint line in the coronal plane. If it would not parallel, then it may displace the fibula proximal or distally according to your track of the screw. And screw should be placed between 2 to 3.5 centimeter proximal to the joint line. During screw insertion, reduction should be held with a clamp to avoid shifting, and the screw should be fully threaded. They should not be lagged. So we have to only put the positional screws, not the lag screws. In the transverse plane, the screw should follow a 25 to 30 degree oblique direction from the posterior lateral to the anteromedial, because the fibula is located posterior to the tibia. This is some pictorial photos during the operation. So after fixing fibula, you will find there is a gap between tibia and fibula, and then go for the syndesmotic fixation. So, whether ankle should be dorsiflexed during screw insertion? Yes, it should be done. Otherwise, over tightening of ankle syndesmosis may be done mistakenly, and it is must to dorsiflex the ankle. In the presence of bony avulsion of the insertion of syndesmotic ligament, open reduction with screw can be done provided the bony fragment is large enough. The surgical indications are if in a standing X-ray and a stress X-ray there is a clear widening of medial clearance space, disruption of the PITFL and deltoid ligament, and on MRI or orthoscopy you found syndesmotic injury. But luckily, it is required only in the 3% of cases. 97% cases will be managed by conservative management. These are some case example having bimalleolar fracture with a syndesmotic injury, and they are tested peroperatively and find there is a syndesmotic injury, and syndesmotic screw is placed after the fixation of both the malleolus. So you can fix by any size of screws, but larger screw may cause discomfort. So there is a no clear-cut consensus about the size, and cortices engaging 3 or 4 more or 4 cortices improves the stability of the syndesmosis. And implant whatever you choose, either the metal screws or bioabsorbable screws, or you can choose the suture anchors, which are the recent trends. So what evidence-based medicine says? No difference between steel or titanium screws, no difference between 3 or 4 cortices, no biomechanical advantage of 4.5 mm screws. 2 more stable screws are more stable than 1, and most retained screws loosen or break. So this is a new thing which in current scenario, foot and ankle surgeons are mostly use, the tightrope. So can this tightrope solve the hardware dilemma? These are the examples of endo button and suture ankle. The advantages are these are flexible fixation, low profile, no need for implant removal, and they allow the earlier weight bearing. But when we compare, comparison is done between the tightrope and a screw, there is no clear-cut difference. There are similar outcomes and similar complications are observed by the AOFS. This is by the tightrope. You can see here, we have no experience about this. So this is X-rays of a Korean foot and ankle surgeon. So this is the post-operative protocol, and on conclusion, surgery is rare for purely ligamentous injuries. Radiographs not reliable for moderate injuries. Anatomical reduction of syndesmosis is the key. Screw and sutures anchors are both equally effective. Thank you so much. Dr. Maneeshi, unmute yourself.
Thank you, sir. Thank you for such a wonderful talk. You have explained almost each and every aspect of the syndesmotic injuries. It is such a complicated issue, and you narrated in such a simpler manner that most of the myths have been removed. I hope so. With us, the another faculty is Dr. Jayant Sen. He is a foot and ankle surgeon from Jaipur. I welcome you, sir. I will request you to give some light on the 5th metatarsal fracture.
Thank you, Dr. Maneeshi Bansal, for inviting me for this Friday Musings program. And Dr. Santosh Singh has been regularly sending me messages, and I try and follow these meetings every now and then. Pleasure listening to Dr. Santosh Singh for the first lecture on the syndesmotic injuries. And as Dr. Bansal said, very simply, he has stated everything. Thank you, UPOA, for having me here. I would request Dr. Bansal to please share my slides.
Sure. Is it okay, sir?
Yes, please. Please take it on the full screen.
From downward.
Yeah.
No. Last cup, just like a cup. No.
Yeah, on the right.
Yes. This one.
Should I start?
Yeah.
Yes.
Please click it on the full screen.
Please share it.
It's already shared, sir.
No, it is not visible on full screen.
Put it on the full screen, Dr. Bansal.
It is there, sir.
Dr. Bansal, do one thing.
Yeah.
On the top of this, the slide enable editing. You click the enable editing and then reshare it. You stop sharing this. Enable editing is click to enable editing and then again share. Yes.
Yeah. So, okay, no problem. We are on the second slide. And the first slide is my topic, which says that not every fifth metatarsal fracture is the Jones fracture. So I lead you through what the fifth metatarsal fractures are. And so the name comes across first from Sir Robert Jones. And this fracture is most commonly seen in the second and the sixth decade. Of course, male predominance in the younger patients and female predominance in the older patients. It's commonly a result of sport activities, but also can happen in more.
Please mute her.
I'm sorry.
Dr. Jain, now you can unmute yourself.
Yeah. So it's commonly a result of sport activities, but can also happen in non-athletes. Next, please. So it's because the strong ligaments between the base of the fifth metatarsal and the cuboid and the base of the fourth metatarsal, which makes this part of the fifth metatarsal relatively fixed. And the diaphysis of the fifth metatarsal is relatively mobile. So this difference in stability makes the metaphyseal diaphyseal junction fractures more susceptible to delayed union and non-union. Next, please. Next, please. Dr. Bansal.
Yeah, already done it.
So this cadaveric study showed soft tissue attachments to the base of the fifth metatarsal. So there's a lateral band of the plantar fascia which attaches on the plantar lateral aspect of the tuberosity, and the peroneus brevis tendon attaches to the dorsolateral aspect, and the peroneus tertius attaches to the dorsal metaphysis. The majority of the peroneus brevis tendon footprints are found in the zone 1, and that's why the hook plate placement demonstrated it to be safe when placed strictly laterally at the proximal aspect of the fifth metatarsal. Next, please. So according to the Lawrence and Board classification, there are 3 zones of injury. Zone 1 is the tuberosity aversion fractures. Zone 2 is the metaphyseal diaphyseal, that is where the fourth and the fifth metatarsal intertarsal joint is there. And zone 3 is the proximal diaphyseal fractures. Zone 1 fractures refer to avulsion fractures of the tuberosity with or without involvement of the tarsometatarsal articulation. And this is caused by forces by the peroneus brevis tendon on the lateral band of the plantar fascia during foot inversion. Next, please. Zone 2 fractures refer to fractures at the metaphysis diaphysis junction and which extend into the 4th, 5th metatarsal facet. And this is caused by forced forefoot adduction with the hind foot in plantar flexion. Zone 3 fractures refer to the proximal diaphyseal fractures distal to the 4th, 5th metatarsal articulation. And these are caused by acute excessive weight bearing of the region or chronic overloading, as in stress fractures. So why is there an inferior healing potential at this metaphyseal diaphyseal junction? It is because the blood supply of the 5th metatarsal metaphysis is by a network of arterioles entering the non-articulating surface of the tuberosity. The blood supply to the diaphysis is by the nutrient artery entering through the middle of the diaphysis, which gives longitudinal branches proximally and distally. And this watershed area of the metaphysis diaphysis junction, which accounts for the highest risk of delayed and non-union of the fractures in this region. So usually we see an isolated 5th metatarsal fracture, but when we see it as a part of a Lisfranc injury, then the management issues are different. So management of the compartment syndrome, if any, and early anatomical reduction and fixation of the Lisfranc joint and the whole tarsometatarsal articulation is required, and delay in treatment of the Lisfranc component is associated with poor outcome, including developing post-traumatic arthritis. So basically today we are dealing with only the 5th metatarsal isolated injuries, but we have to be aware that the Lisfranc injury associated with it has a different permutation. Next, please. So zone 1 injuries are have no significant difference in union and refracture rates between different conservative treatment modalities. Next, please. And next, please. So functional treatment with early, no, the previous one, please. So functional treatment with the early weight bearing provides a better functional outcome and earlier return to work than treatment by a short leg cast with non-weight bearing walking. So this is an important point in the zone 1 fractures. And this functional treatment could be orthopedic shoe, Jones bandage, dressing or elastic bandage or a crepe bandage, that is leading to a quicker recovery. Next, please. So this study, 5th metatarsal fractures in zone 1, radiography was performed to assess the degree of fracture gap and metatarsal length and various managements, whether the gap was 2 mm or less, and they were treated either with a short leg cast, and the gap was more than 2 mm. Group B were treated with open reduction internal fixation, and Group C with short leg cast. And radiographic union was achieved in all cases. And so no difference was seen in the final VAS scores for patients with longer metatarsals when compared to those in whom the metatarsals are unchanged or shortened. Because this point was noted because one of the studies that showed had implicated shorter metatarsals or longer metatarsals with more non-union rates. So significant improvement regardless of the initial fracture gap and type of management. Next, please. And zone 1 and 2 fractures featured excellent results with immediate full weight bearing. Consequently, all type 1 and 2 fractures should be summarized as epimetaphyseal fractures. Fracture displacement, articular involvement, and number of fragments did not influence the outcome. Therefore, functional treatment should be recommended for all epimetaphyseal fractures. According to the Tokes classification, now this was based on for zone 2 and 3 and for formulating a treatment plan. So in type 1, which are the acute fractures, there's a narrow fracture line and no intramedullary sclerosis. Type 2 is the delayed union where there's a wide fracture line and intramedullary sclerosis. And type 3 is the non-union, which is complete obliteration of the medullary canal by the sclerotic bone. Next, please. So zone 2 and 3, there is 95% union rate, satisfactory long-term results, and satisfactory functional outcome with non-operative treatment by short leg cast and immobilization. But the main disadvantage, that is the delayed union time and longer time to return to function. And 8 out of the 44 patients required secondary fixation surgery due to delayed union. So with conservative treatment with non-weight bearing in a short leg cast for 6 to 8 weeks for acute fractures in the non-athletic group is recommended. And surgical fixation is recommended in the athletic group for earlier union and return to function, and also in cases of delayed or non-union cases. Next, please. So what are the operative options? They can be either an intramedullary screw or a tension band wiring, a differential pitch screw, percutaneous bicortical screw, or a hook plate. Next, please. So fixation with an intramedullary compression screw with or without bone graft is the most commonly reported technique. And reaming of the medullary canal before screw insertion is advised to ensure tight fit of the screw to the endosteum. A partially threaded screw is used, and all the screw thread must pass through the fracture line in order to achieve fracture compression, as we do in any lag screw. And there is no correlation between the size of the screws and biomechanical advantage. And the most important point is the insertion, which has to be just inside the beak of the base of the fifth metatarsal. Next, please. So a larger screw may provide a better pull-out strength, but it will also increase the risk of diaphyseal fracture during insertion. So usually now we use a 4.5 mm or a 3.5 mm screw depending on the bone size. There is a 100% union rate, high satisfaction, and no refractures in a group of high physical demand athletes using 4.5 mm screw cannulated intramedullary screw fixation. Similar excellent results were also demonstrated in another more recent study. So screw fixation is the usual go-to method for athletic patients, non-unions, and delayed unions. Next, please. Other methods like a tension band wire have been used with comparable outcomes, but there is a risk of sural nerve injury and neuralgia is reduced. Next, please. Variable pitch screw and tapered screw have been used, but clinical evidence at present is still limited. Not many papers in this regard. Next, please. So, retrospective review of 37 professional football players, and the mean return to play was in about 10 weeks, and mean time to complete radiological union was about 12.5 weeks. So return to play at 8 weeks or less resulted, this is the important point here, return to play at 8 weeks or less resulted in a higher risk of delayed radiological union, but this neither prevented the athletes from continuing to play football, nor did it affect the ultimate risk of non-union. Next, please. What are the post-op rehabs? Well, short leg cast for about 2 weeks and then a walking boot, progressive weight bearing from 4th week onwards. At 6 to 8 weeks, full weight bearing, walking is allowed, and return to sports should only be allowed when there is radiological evidence of union and the patient is clinically asymptomatic. Next, please. So the rehabilitation plan must be accepted by patients preoperatively, since premature return to sports activity is believed to cause delayed union and refracture, especially in athletic patients. Next. So what are the contraindications of surgical treatment? Well, feet with vascular compromise, neuropathy or local infection. Diabetes mellitus itself is not an absolute contraindication, provided the vascular supply and the protective sensation of the extremities are still intact. What are the complications? Well, delayed union, non-union and refracture, but very low. A low non-union rate of about 0.5 to 1% was reported in zone 3 fractures, and non-union is treated conservatively in In conservatively treated zone 2 and 3 fractures was higher. So delayed union and refracture of a higher rate was seen in the zone 2 and 3 fractures compared to zone 1 fractures. Next, please. For tuberosity avulsion fractures, failed conservative treatment, screw fixation with or without bone graft, and excision of the extra-articular avulsion fragment are the most common treatment options. For fractures of zone 2 and 3 non-union, it should be again, as I discussed already, medullary curettage and inlay grafting or an intramedullary screw fixation. Yes, please. So revision of previous screw fixation, a larger diameter screw and re-reaming of medullary canal is required. And tension band wiring as a second feature has delayed union where intramedullary screw fixation had given promising results. So possible complications of surgical fixation like anywhere else, wound infection, rupture of peroneus brevis tendon, if it is especially when the hook plates are malpositioned, peroneal nerve irritation, sural nerve injury, impingement by a prominent screw head. So it needs to be placed correctly. Screw missing the medullary canal, well, that's a surgical disaster. An iatrogenic fracture of the metatarsal bone and metatarsalgia that can happen when you are using a too big a size of the screw compared to the medullary canal diameter. Next, please. So wound infection and tendon or nerve injury can be avoided by careful soft tissue handling and using a low profile implant. Impingement by screw head can be prevented by adequate countersink of the cortex before screw insertion and can be managed by wearing more spacious shoes. And the placement, the initial entry point has to be inside, not at the base of the fifth metatarsal, so slightly medial to it. That way the screw head will not be prominent. And screws missing the medullary canal and iatrogenic fractures can be avoided by proper surgical technique and careful choice of a suitable sized implant. Yes. Next, please. So take home message, proximal fifth metatarsal fractures are common. Knowing the anatomy is important for understanding the mechanism. Classification by Lawrence and Bott and that by Togg help to formulate appropriate treatment strategies. Fifth metatarsal fractures associated with Lisfranc injury must be distinguished from isolated injuries because their prognosis and management are different. Avulsion tuberosity fractures, zone 1, should be initially managed conservatively with functional treatment and early weight bearing since the union rate and functional outcomes are good.
Yes, Dr. Jain. Dr. Jain.
Please. Next, please. Next, please. Athletic groups, early surgical fixation with intramedullary. No, previous, please. Yeah. Athletic group, early surgical fixation with intramedullary screw is advised for shorter union time to return to sports. And for cases of delayed and non-union, surgical treatment with or without bone grafting is recommended. Post-operatively, rehabilitation plan should be agreed and strictly followed by the patient. Next, please. Complications of proximal fifth metatarsal fractures include delayed union, non-union, refracture, soft tissue complications, and implant impingement. They can be prevented by careful soft tissue handling, proper surgical technique, and suitable choice of implant. Symptomatic delayed union, non-union, and refracture should be treated with revision, intramedullary screw fixation, and bone grafting. Thank you. Thank you so much.
Thank you, Dr. Jain, for beautifully elaborated this metatarsal fracture. Normally, there is a myth. Every base of the fifth metatarsal is labeled as a zone fracture. You clearly demonstrate how we can differentiate and what are the treatment strategies to manage these type of fractures in zone 1, zone 2, and zone 3. Thank you, sir, so much.
Yes.
With us, another faculty is an expert in Ilizarov. He treated everything with the Ilizarov only. So I welcome Dr. Mohd Younus from Prayagraj Orthopaedic to give his talk on the Ilizarov in foot and ankle. Dr. Younus, please.
Hello, everyone. Is my audio and warm greetings to all the honorable members of this Zoom meeting. Today we shall be discussing some principles. We can't discuss all of the principles of Ilizarov application in foot and ankle over a short Zoom meeting. We'll be discussing some principles of Ilizarov in foot and ankle, particularly with reference to deformity correction, which we commonly see in our day-to-day practice. We need to know how to apply a balanced foot frame in a deformity setting. We need to have a good idea of what are the components of the Ilizarov technique that we generally use, particular reference to the foot. And in this, we use as those who do tibia Ilizarov regularly, they might not have seen foot rings. They might not have been exposed to foot rings. So I would like to introduce these two types of foot rings. We call this a static foot ring and dynamic foot ring. Static foot ring is a foot ring that stabilizes the foot in a static manner. There is no intrinsic movement within the ring per se, whereas they are rigid rings. Whereas a dynamic foot frame will have components to correct deformities appropriate to the situation. Like, for example, if there's a abduction or a deduction of the foot, deformity that needs to be corrected, it gets corrected in this manner, like this. And if there is a cavus deformity, that gets corrected from this situation to this situation. So this is how we correct a cavus deformity. And if there is a pure equinus setting, like endophase contracture or chronic long-standing equinus deformity, where we correct by Ilizarov, we'll be using a rigid foot frame. The entire deformity correction happens above the foot in the ankle level. So the foot ring that we apply is a rigid foot ring, and that is an example. I would like to present these situations with the help of clinical examples so that it gets easily understandable. This is a patient case of paralysis polio with stiff equinus deformity, the shortening of the limb. There is a coxa valga also. There is a femoral leg segment shortening. There is a tibial segment shortening with equinus deformity, huge limb length discrepancy. There was also compensatory scoliosis deformity in the lumbar spine. The valgus can be easily seen here. So here we are correcting this equinus deformity with the help of a rigid foot ring and a pre-assembled equinus correction frame. So here we have a tibial frame and a foot frame and connected by equinus correction assembly. And this has to be implanted right into the patient. A pre-assembly will save a lot of operative time on the table. So we just put it on the patient and start the deformity correction. The patient also needed a tibial lengthening with the help of a proximal tibial corticotomy. And this amount of shortening was corrected in the tibial segment. And the equinus was corrected. The LLD was corrected with the help of tibial lengthening. Then the patient also underwent successful deformity correction of the hip with the help of Ilizarov method only. And we were able to correct the coxa valga and offer her a very stable pelvis and a very functional limb. In case there is a cavus deformity along with the equinus, then we have a frame in this shape. It starts like this, with the cavus being incorporated into the frame. And as you correct deformity, the cavus flattens out to form a proper corrected foot. Along with that, you can correct the equinus in this manner. So equinus gets cavus gets corrected first, the equinus gets corrected later, leading to a anatomical correction. Sometimes we face intrinsic foot deformity in the form of equinovalgus with a 4-foot abduction deformity or an adduction deformity. This is a patient, a case of spina bifida with meningomyelocele, the operative childhood. These were the deformities that the patient was left with. We have a 4-foot abduction deformity that needs to be corrected. Along with that, equinovalgus needs to be corrected. So we accommodate this deformity in a foot ring and appropriately correct the deformity one by one and offer a stable correction. We can also have the most common polyaxial foot deformity that we commonly see in our practices, neglected CTEV.
Dr. Younus, you please make your screen full screen, which is not visible and not rotating even.
Is it not full screen yet?
No, please make it a full screen.
I am in full screen, Dr. Maneeshi.
But it is not visible to us in the full screen, and neither it is moving up.
Okay, so now
can you reshare?
You want me to reshare? I'll exit once again. Now it is without full screen.
Now it is there, but it is not. Still, it is not full screen.
Now is it full screen? Is it full screen now?
No.
Is it full screen now?
No.
At least is the photograph seen?
Photographs are there, but it is not in the full screen. Okay, you carry on, but the slides are not moving.
Slides are not moving.
No.
Still.
You just
I'll stop share and once again share.
Reshare.
Now how is it?
No, it's okay.
Okay, good. So now polyaxial foot deformities. Okay, polyaxial foot deformities needs to be accommodated into the Ilizarov foot correction frame accordingly. Like for example, if there is a 4-foot adduction deformity, you need a separate 4-foot ring, a separate hind foot ring, and a separate tibial ring. Like in this manner, and we gradually correct deformity one by one from below upwards using the principles of kite or using the principle of pond setting. So we just corrected any type of rigid deformity can be corrected successfully with Ilizarov. And I would like to explain it with an example. This is the case of bilateral CTV, a neglected CTV presenting at the age of 12 years. And we have avus, we have 4-foot adduction, we have equinus, and we have heel varus. All of this, the entire shebang is there. So we accommodate every one of them in the pre-assembly. There is equino cavo varus correction along with 4-foot adduction deformity correction. So all of it is accommodated in the pre-assembly. Then we implant a heel ring. We have to ensure that the heel ring is exactly in the same plane as the heel skin, and it should be in parallel to the heel skin and perpendicular to the heel axis. That has to be ensured. Then once that is done, we apply a tibial ring that has to be exactly perpendicular to the tibial weight bearing axis. We should make sure that the fixator is equally grotesque, equally damaged as the ring. The deformity should be there. There is someone scribbling on the screen. Please, Dr. Jayant Sen, if I'm right. Thank you. And we have to have a tibial ring exactly perpendicular to the long axis of the. How do we remove it, Dr. Maneeshi? A lot of
Can you remove this?
How do I do it? Okay, so I'll proceed. The tibial ring has to be exactly perpendicular to the long axis of the leg. The foot heel ring should be exactly parallel to the surface of the heel. Then we start with the insertion of the foot 4-foot ring that has to be exactly in the orthogonal to the foot 4-foot axis. We also do a minimal plantar fascia release here to correct the avus beforehand, so that the deformity correction becomes much more simpler. So you don't have to correct avus separately before correcting the 4-foot adduction. Now, after the assembly is done, this is how the patient comes out of the OT. We have the entire deformity still present. None of it has been corrected. We have not done any soft tissue release here. Everything is done percutaneously. This is in fact called a non-operative Ilizarov method. Here we have not used the scalpel at all. We have only inserted the wires, and the deformity is still as it is as before the surgery. Now gradually we start correcting the deformity. First gets the 4-foot adduction gets corrected, then equinus heel varus gets corrected, then equinus gets corrected, and we have a almost anatomical looking limb, and we maintain the deformity correct in a corrected position for double the time that we took for the correction of deformity. Assume we took 1 month for correction of deformity, we give the resting time as 2 months, sometimes even 3 months, to make sure that the deformity stays corrected before we do the fixator removal. Sometimes we even have to do a hyper correction in order to make sure that the loss of correction that happens after removal gets accounted for. This is after fixator removal. We give an orthosis. This is the clinical picture of the child after complete deformity correction, and the most plantigrade normal looking foot, which is absolutely flexible, and the patient is able to walk with normal footwear, with a normal barefoot. We also have operative corrections in which we will be using the scalpel. The Ilizarov surgeon, along with appropriate Ilizarov fixator induced with the deformity correction, we will also use certain osteotomies or orthodontic techniques that is called operative correction of the deformities. I would like to show some examples. We use the calcaneal osteotomy. We use the U osteotomy. It happens somewhat like this. We also have a more commonly used V osteotomy. V osteotomy is a workhorse osteotomy for a patient with the complex deformities in foot. So technique, we all are aware how V osteotomy is done in an open method, but here we use a percutaneous minimally invasive V cut on the talus and the calcaneum, And how we exactly do it? We cut through the talus and the calcium in this manner, and this leads to stable correction of the deformity and ensures that the loss of correction is not there. Dr. Maneeshi, if I exit, the annotations will go off.
Pardon?
If I exit and go again, the scribblings will go off.
Maybe you can retry.
I will stop share. I think yes. Now it's much better. So we have a osteotomy that ensures that the joints are not destroyed. At the same time, we have triangular regenerative columns that are formed that make sure that we are giving a more stable and a more sustained deformity correction, not entirely dependent on ligamentous ligamentotaxis principles. We are using osseous principles here. So one example that I would like to show is this V-osteotomy. This is how exactly we do the V-osteotomy. V-osteotomy can be used for correction of cavers, varus, adductors, planus, whatever be that. You can correct flat foot, you can correct cavus foot, you can correct forefoot adduction, you can correct forefoot abduction, you can correct heel varus, you can correct heel valgus, whatever it is. The entire shebang of foot can be managed with V-osteotomy. That's why we call it the workhorse osteotomy in the Ilizarov foot surgery. So here is a patient. This is a paralytic poliomyelitis. This is a spastic cerebral palsy. Here, if we just rely on ligamentous principles and use like the general CT, we correct it, there is a high chance that we might be having a loss of correction post-operative. So here we resorted to a V-osteotomy. There is equinus, there is forefoot adduction, there is cavus, there is heel varus. The entire thing is there. First thing we apply the heel ring, then we apply the foot ring, and also the tibial ring. Everything is done. And this is the direction of the osteotomy. You can see this is the first direction of the osteotomy that is going in for the posterior limb of the V-cut. This is the osteotomy going in for the anterior limb of the V-cut. And these two limbs, once done, as we correct the deformity, we form new regenerative columns here that make sure that the foot is, length of the foot is not lost, and the deformity correction is more sustained and more stable. So this is a child during the deformity correction stage. We have to ensure that the toe drop does, in such grotesque looking deformities, particularly in spastic situations like spastic cerebral palsies, we have to ensure that the toes are prophylactically fixed with the intramedullary wires to ensure that there is no claw toe that develops during the deformity correction. As we are correcting here, we generally develop claw toe deformities here and knee flexor deformities. So we have to ensure that no new deformities are created during the correction of an existing deformity. So this is the complete correction of the heel varus, complete correction of equinus, varus, abduction. The foot is anatomical and everything looks perfectly normal. And this is the patient ambulatory status with the fixator on. And this is the patient's weight bearing status with the fixator on. And this is just after fixator removed. You can even see that the range of motion is quite good. And we have a functional foot, a flexible foot, at the same time, a stable foot. So we also have certain other principles like arthro disease. I would like to discuss, but I don't think is the time.
I think we can have a.
We can have it in some other subsequent topic. So if there are any doubts or questions or apprehensions about the topics so far, I would like to.
Thank you, Dr. Younus.
Thank you.
Please stop sharing the screen. Dr. Younus, please. Yeah. Thank you, Dr. Younus, for a wonderful presentation. Definitely, it is very enlightening, and we can have a lot of corrections with the Ilizarov only. We have among us senior panelists, Dr. KD Tripathi and Dr. Gyaneshwar Tonk. They may ask something. I think Dr. KD Tripathi, please enlighten us, and if you have any queries, please ask them.
Thank you, Maneeshi. It was a wonderful session, and first session was Dr. Santosh Singh's session about the syndesmotic fracture. Dr. Santosh, if there is, are you there? Dr. Santosh?
I think he.
Dr. Santosh?
Dr. Santosh is not here.
Then the second lecture was with the very common injury, that is Jones fracture, Zone 1, 2, and 3. I think Zone 2 is the real Jones fracture. Dr. Jayant Sen, are you there? Dr. Jayant? think he also left.
No, he is there, but he is not still mute.
Dr. Jayant. Then Dr. Younus lecturer is a very wonderful job he has done, and like correction without opening the joints, without opening the soft tissues. The Ilizarov is a very wonderful method to correct these deformities. Congratulations, Dr. Younus. You have done the very nice job with these patients. Can you do the hybrid job, like do the soft tissue correction and then maintain the some bony osteotomy, and then do the, because that saves the time, because Ilizarov frames, they take a lot of time for this. So you can do the hybrid open and the close correction both simultaneously.
That is a very good question that you're asking, Dr. Tripathi. The thing is, generally we resort to Ilizarov when assume in a CT situation, we get the child at or about 8 years or 9 years or 10 years. That is a situation where we do Ilizarov. Here, assume we do a triple osteotomy or a triple arthrodesis or any of these procedures. We end up having a short foot. That is the first disadvantage. That's a very gross disadvantage. Patient will be there in unilateral situation, he's a 7-size shoe on the left side and 3-size shoe on the right side. That is a very difficult situation for a child. But if we have a method that ensures that we can give foot length equality on both sides, at the same time, functional joints, that would be a much better. There are surgeons who generally combine lengthening along with equine correction, some FHL, tibial posterior, and these tenotomies, like we do in a post-medial soft tissue release Turcot's procedure that we used to do in our good old days, that almost completely vanished before an ankle surgery, the current scenario. But if we end up doing those, what we end up is we end up having a stiff foot, we end up having and then those tenotomies and tendon lengthening do not significantly contribute in deformity. Actually, this foot has been in that deformed position for such a long time that these do not obey to soft tissue procedures. We need big guns. We need to apply the Ilizarov fixator. And once we start lengthening, what happens is, if we are doing a purely ligamentous Ilizarov, like for example, a ligament based principle without osteotomy, we will be doing just correction. What happens is the ligaments on the contracted side keep lengthening. The ligaments lengthen, the tendons lengthen, the joint capsule lengthens, the artery, nerve, everything lengthens. But assume we want to at least have a partial correction through soft tissue procedure, rest of it by Ilizarov, just to avoid saving time, or some make it more easy for the Ilizarov surgeon. It doesn't go that way, because we end up lengthening the tibial posterior tendon, but it will not slide. The deformity joint will stay there. It will such a long standing deformity. And what happens is we cannot lengthen the tibial nerve or the posttibial artery. So that the entire contracted ligament situation cannot be offered simultaneous correction in one go on the table. So it will be better when Ilizarov surgeons are able to form new bone in bone loss situations, in segmental bone loss situations, we are forming new bone. Forming new soft tissue is much easier. So we are forming 1 millimeter per day, 0.25 millimeter 6 hourly. But here we can do a much higher speed and with much less pain. So there is a gross misconception among the non-Ilizarov surgeons that we need to have some soft tissue component to help the Ilizarov surgeon. No, Ilizarov surgeon per se offers a very huge amount of time.
Someone was asking question.
If you want to give a bone correction proper and osteotomy, you can add a U, you can add a V, or you can add arthrodesis in tough situations like spastic cerebral palsy, or in
it's problem with this system.
Situations like meningomyelocele, and foot sequelae and all that. So we'll have to add bony procedures in such situations where we are getting lost.
Messaging it.
Hope that answers your question.
Thank you. We got it very well.
Dr. Jayant is there with he has got some problem with the system. So what is your question, Dr. Tripathi, please?
I think when these Jones fractures are part of this frame, then how to manage them?
Hello.
In the meantime, we'll discuss with Dr. Gyaneshwar. Dr. Gyaneshwar, you can unmute yourself, Dr. Gyaneshwar.
Sir, good evening.
Good evening, Gyaneshwar. Good evening, welcome.
Nice to see you.
Yeah, very nice.
I think all the lectures were very good. I want to thank Dr. Maneeshi for adding me as a panelist here.
It was a pleasure, sir. It was a pleasure.
I also want to ask, sir, in Jones 2 and Jones 3 fractures, as Dr. Sen has said that there are a lot of chances of non-union and malunion. So, is it same with the operative method and it is also same like in non-operative method? Or in operative method, we has more non-unions or malunions rather? I want to ask him if he has been here, what the evidence says. Because study was more of evidence based. Because one is always supposed to be an avulsion fracture.
Can I answer that question regarding the Lisfranc with the fifth metatarsal?
Yeah.
Am I audible?
Yeah, you are audible.
Because the sound to me is coming very low. I don't know why.
You are audible.
But whenever we have a Lisfranc along with the fifth metatarsal, then it is the Lisfranc which will take priority.
Okay.
The Lisfranc injury needs to be managed, and so you need to watch out for the compartment syndrome first of all, because usually then it's a very gross injury. And if it's because when you have a Lisfranc which has a fifth metatarsal along with it, that usually means it's a divergent injury or a total injury. So we have to be very careful with regards to the compartment syndrome 1. And usually you would need to do a stabilizing with an external fixator to hold the thing, and the definitive fixation, of course, once the swelling comes down.
Okay. That's it. Dr. Gyaneshwar has asked one question. Dr.
Good evening. I want to ask, as you have said us that Jones 2 and 3 are having approximately 66 to 67% chances of non-union and delayed union and other complications.
Yes.
Is it with these results with operative methods only, or it is same in the non-operative methods, or more or less?
So these are when you have a non-operative method. So the management for that is, so the result, this is one particular study which showed up to, but there are other studies which have shown only about 18 to 25% also. So all the results that I've quoted are from different studies. So still the treatment remains that for the acute injury, you will go in for a conservative treatment if it is a non-athletic individual. If it's an athletic individual who needs a faster rehab, or it's a delayed union or non-union, then you go in for the operative management. And usually the screw fixation is great.
Dr. Jayant, which screw to fix it? Do you measure the medullary canal by just reaming it, or you just go for 4.5 in all patients?
No. And actually in females, I go for 3.5.
3.5.
Yeah,
and
because Indian females.
Osteoporotic elderly patient in the elderly age group.
Yes.
You go for sometimes 6.5 or 4.5 will do.
No, I've never used a 6.5. Never in a metatarsal, fifth metatarsal, never. It's only for the Americans.
Yeah, and sometimes there is a dorsal bowing in the metatarsals, particularly in the fifth one. So how to tackle that situation?
Yes. So that is a part of the preoperative game plan that you do. You try and push the screw as long as you can, but it does not necessarily have to be till the neck or the distal half. You can push it as much as, so if you're using just a 16 mm thread, even if it crosses the fracture line, that should be good enough. But the longer that you can put it, and so if you get the screws into the diaphysis, then it's a good idea. But that is where the surgical judgment comes in, so that you don't end up with an iatrogenic fracture.
Thank you.
Then is there any indicator by which we can predict which fractures are more prone for the non-union in these metatarsal fractures?
Yes, sir. The zone 2 fractures. The zone 2 fractures are the ones which are likely to have a higher chance of non-union and delayed union. The zone 1 fractures usually heal very well. Hello?
Dr. Santosh has come or not?
No, sir, he has gone somewhere. He has to join the PGICL, so he has left.
Okay. Dr. Jayant, can we discuss Dr. Santosh's lecture?
Yes,
that
please.
If there is bony fractures like avulsion, Wogstaff or Tilloch's or Walkman's, then
Yes.
you fix the fragment, and it's not necessary to go for these syndesmotic screwing.
Yes. So basically, you need to create a stable situation. And if you've been able to, if the fragment is big enough for the Tilloch's to be fixed, then you don't need to.
Yeah.
As Dr. Santosh already said that, we need to be aware of the syndesmotic injury. In his talk also he has said, but the percentage is not very high. So if you have done a stable fixation, then you don't need to fix it.
Like if it is
The need for this.
Yeah, if it is posterior malleolus, you fix the posterior malleolus. Most of the ligaments are stable. Then you need not to. You need not to go for the.
Absolutely.
What
because that
opinion?
itself works as a syndesmotic injury.
Yeah.
Fixation. Yes.
What is your opinion, Dr. Gyaneshwar? Dr. Gyaneshwar?
Sir, I think also the same. If we fix the posterior malleolus, I think all the ligaments are in position and they heal with period of time. So they are not going into landing up into chronic pain.
Yeah, either posterior malleolus or Tilloch's fracture. If it is big, we fix it and we leave it as such, and there is not much instability. We can go. We can go. Yeah, that's great. That's great message. Okay, Maneeshi, I think.
Thank you, sir. Thank you.
Any other question from the audiences? I think just audience. I don't think there is any. See the chat box if there is any.
So we don't have any question from the audience.
Then,
thank you so much. Thank you, the learned speakers and the panelists. Thank you so much for joining this webinar.
Dr. C.P. Pal is not there.
So he has to also to join the PGICL.
Okay.
Thank you all, sir. Thank you, Jayant.
Thank you.
Okay, thank you for having me. Thank you for having me.
Good night.
I'm sorry there was a slight problem with my laptop today. So I had to request Dr. Bansal for the support. And I don't know, the volume is just falling off.
Thank you so much.
And we are looking forward to see you there in November, I think, no?
Yeah. Please, pleasure. Thank you for having me there. And I look forward to meeting you all. Thank you.
Thank you,
everyone. Good night.
Okay, good night.
Thank you.
Good night. Thank you, sir. Thank you.
Bye-bye. Good night.